Good evening, friends. So today we'll be discussing about toxidromes. Myself, Dr. Ajay Kumar Gupta from Max Hospital, Vaishali. So first of all, what is a toxidrome? So just understanding a toxidrome by definition, it is a syndrome which is caused by the dangerous level of the toxins. Or in term means it is often used for the consequences of the drug overdoses. And there are many common symptoms which are associated with these toxidromes, and they may be like dizziness, disorientation, nausea, and also they indicate a medical emergency which requires the treatment of the particular poison. Okay, so now today we'll be discussing what all are the types of toxidromes which are commonly presenting in the emergencies, and how to deal with them, or first of all how to diagnose them. So I've tried to make it easier to understand. Just let me know if I can explain it further. So there are different types of toxidromes as I was discussing. So these are the outline in which we'll be presenting our talk today. First is the anticholinergic toxidrome, then we have the cholinergic toxidromes, then the opiate toxidromes, then the hypnosedative toxidromes, sympathomimetic toxidromes, serotonin syndromes, the neuroleptic malignant syndromes. I know means these words are a bit malignant themselves, but we'll try to understand them, and maybe then we'll be more comfortable with these toxidromes. So first of all, if we take the anticholinergic toxidromes, so in the anticholinergic toxidromes, we have the drugs which have the affinity for the acetylcholine receptors in our body, and they antagonize the muscarinic or the nicotinic receptors. And the majority of the blockade in these toxidromes is at the muscarinic receptors, but at high dose, some of the blockade it occurs at the nicotinic receptors also in the autonomic ganglia and at the motor end plates. So So what do we means by the muscarinic receptors, and where are they located? So there are different types of muscarinic receptors like the M1, M2, M3. So M1 is mainly present in the central and the enteric nervous system. Then M2 is mainly in the heart. The M3 is in the smooth muscles, like the M3 receptors are responsible for increasing the exocrine gland secretion. They increase the gut motility. They have the action of meiosis by the pupillary sphincters. They have the accommodation by the ciliary muscles. Then they have the bronchoconstriction and the bladder constriction. So therefore, means the muscarinic blockade, it gives a typical or a classical anticholinergic phenomena, which we call it as dry as bone, red as beet, hot as hair, mad as hatter, and blind as a bat. So when I was a PG student, means I used to first just cram up these things. Then I made myself to understand, means what do you mean by dry as bone? What is red as beet? What is hot as hair? Mad as hatter? So I have tried to just illustrate in a diagram. So if you can just see this diagram, we can very well see that this is sorry, this is the blind as this is the blind as a bat. So this is the mad as hatter, means in previous days, in 19th century, the hats, they were made by the hatters, and a chemical was used to take out the fur from the hat, and that chemical, when inhaled, they caused a maniac and a madness in those hatters. Hatter is a person who makes the hat. So there is a confusion which is created, and then we see the mid-dryas because there is no meiosis. Okay, then the skin is flushed, so you see a red as beet, means this skin over the face is red, and there is a dilated pupils. Then you have a very dry mouth. There is a urine retention. There is a shaking of the hands, and the person, it seems like he's grabbing the invisible things. Then there is a increase in the heartbeat. The tachycardia is there. You don't have any bowel sounds. There is an absent bowel sound, and the patient is hot as a desert. Hypothermia is there. So these are the central effects. Like if we talk about the central effects and the peripheral effects, so we have some central effects, And then we have the peripheral effects. In the central effects, we have the agitated delirium, like I was just mentioning about the word mad as a hatter. So what we means when we say mad as a hatter, means there is a fluctuation in the mental status. Sometimes the patient will be maniac and sometimes he will be depressed. Then the patient will be confused. He'll be very restless, fidgeting, and always he'll try to pick up things in the air. Then he'll be mumbling, slurred speech will be there, and there will be a disruptive behavior. So these are the features of mad as hatter. Then, as I said, that patient will be shaking, he'll be having tremors, and he'll be having myoclonic jerks. So these are the myoclonus. Then if the patient may have a seizure also, and if the patient presents late, the patient may present in coma also. Then if we talk about the peripheral effects, the patient will have mydriasis, there will be a pupillary dilatation, and that's why it means when there is a pupillary dilatation, because of the loss of accommodation reflex, the patient will not be able to see anything, or the patient will present as a blind patient. So we say blind as a bat, because bat is not able to see in the daytimes. Then the heartbeat is high, like I mentioned there. There is a dry mouth, then flushing, hyperthermia, the urinary retention, and the absent bowel sounds. So these are the features of anticholinergic toxidromes. So now, what all are the sources of anticholinergic toxidromes? So if we talk about the sources, the patient will give a history of atropine, the patient will have the history of anti-epileptics or antihistamines, the anti-Parkinson medications like amantadine, benzotropine, then the antipsychotics are very common like chlorpromazine, clozapine, olanzapine, droperidol, haloperidol, and quetiapine. Then the patient may come with a history of scopolamine or anti-motion sickness agents like scopolamine, and the GI antispasmodics like hyoscyamin, and the GU antispasmodics like oxybutyn and solifenacin. Means any overdose of these drugs can cause such symptoms. And also means if we know about the belladonna poisoning, the brugmansia, the dhatura, henbane, mandrake, these are all plant sources which cause such type of symptoms. So sometimes we find patients who come with the dhatura poisoning also. So these all patients will come with these type of symptoms. Then also with the skeletal muscle relaxants like dantrolene, SSRIs like paroxetine, then tricyclic antidepressants like amitriptyline, clomipramine, and nortriptyline, and also with some topical eye drops like the cyclopentolate, hometropine, and tropicamide. The signs and symptoms in these patients are variable. Means we cannot find all the signs and symptoms in these patients. Means it is not a classical presentation always. Okay, so we have to reliably diagnosed by taking out the history of such patients. So in the differential diagnosis, we have the encephalitis, the hypoglycemia, the hyponatremia, the ictal phenomena, then the neurotrauma, sepsis, serotonin syndrome, the subarachnoid syndrome, Wernicke's encephalopathy. So these are the various differential diagnoses. So, but by taking a proper history and by examining the proper signs, we can just make it out that what type of patient we are dealing with. Okay. So, like this treatment of all toxins, there has to be treating agitation. Means you have to avoid treating agitation with anticholinergic drugs. Then the antidote of this anticholinergic toxidrome is physiostigmine, which is a reversible anticholinesterase inhibitor, and it is to be given when there is agitated delirium which is not controlled by benzodiazepine sedation, or there is an isolated anticholinergic poison. Okay, and you are to not use if the patient is having a bradyarrhythmia, or there is an intraventricular block, or the AV blocks, or bronchospasm is being found. And also the duration of action shorter than the delirium. Means if the duration of action is shorter than the delirium, the repeat dose may not be required. Okay, so this was the short and the gist about the anticholinergic toxidrome. And now we come to the cholinergic toxidrome. So what is the cholinergic toxidrome? The cholinergic toxidrome, it results when there is an increased acetylcholine activity at both the central and the peripheral nicotinic and muscarinic receptors. and they can arise from either cholinesterase inhibitors like the organophosphates and carbamates, and also by the cholinomimetics, which have the direct agonistic action at the muscarinic or the nicotinic sites, like the pilocarpine or muscarine. And if we talk about the symptoms, the central nervous system and the neuromuscular system symptom both are found. In the central nervous system involvement, there is agitation, there is a central respiratory depression. The patient may have coma, confusion, lethargy, and seizures. And in the neuromuscular symptoms, the patient may have fasciculations and muscle weakness. Okay, so this is a typical cholinergic syndrome patient. So the patient will have the parasympathetic muscarinic effects like the abdominal cramps, bradycardia, bronchoconstriction, bronchoria, diarrhea, then lacrimation, meiosis, salivation, urinary incontinence, and vomiting. So we just see this picture. You have the pinpoint pupils, meiosis, then there is a sweating, the patient will be sweating like anything, and all the sites, they will have increased secretions. So whether it is the skin from where the sweating is there, whether it is the nose from where the rhinorrhea is there, whether it is the eyes from the lacrimation is there, or whether it is from the mouth where the salivation and bronchoria is there, and whether it is the gut where the vomiting is there. And also you have the bradycardia and increased urination and also the diarrhea. So there is a urinary incontinence also, and there is a diarrhea also. And then we have the sympathetic nicotinic effects, which cause the hypertension, mydriasis, sweating, and tachycardia. So if we talk about the cholinergic toxidrome, in the cholinergic toxidrome, we have the sludge, which we have already talked about, and the dumbbells. Like the dumbbells, it includes the diarrhea. So we see the diarrhea, urination, meiosis. It's just a repetition of what we have seen in the previous slide. So these are the various classifications. Like we can just put it. These are the mnemonics, I should say. That we have the killer bees of the bronchoria and bronchospasm, and you can just mug it up like sludge. So sludge mein salivation, lacrimation, urination, diarrhea, gastrointestinal distress, and emesis. And in dumbbells, you have the diarrhea, urination, meiosis, bradycardia, emesis, lacrimation, lethargy, and salivation. But instead of these mnemonics, if we just focus on this picture, you don't have to mug it up. And this picture, if it is in your mind, then you can very well identify a patient of cholinergic toxidrome. So now coming to the sources of this toxidrome, we have the acetylcholinesterase inhibitors like the organophosphates, carbamate insecticides, the chemical warfare nerve agents like sarin, and the agents which are used in dementia like donepezil, gelantamine, riastigmine, tacrine, and also the patients on myasthenia gravis treatment like the idrophonium, neostigmine, physiostigmine, and pyridostigmine. Though commonly we find only the carbamate and the organophosphate things, usually the dementia and myasthenia gravis, if the patient is on regular follow-up from the psychiatrist or the neurologist, usually we don't find a cholinergic toxidrome till the patient has purposely taken an overdose. Then we have the acetylcholine agonists, which include the muscarinic agents like the acetylcholine, carbachol, and pilocarpine, and the nicotinic agents like nicotine, and also some mushrooms which have the muscarinic action. And then we come to the differential diagnosis, because we have a varied number of presentations, and there are some syndromes which also mimic this cholinergic toxidrome. Like if we talk about the causes of weakness, then we have the Guillain-Barré, the myasthenia gravis, botulism, and the cardiotropic intoxication resulting in bradycardia and vomiting, like the digoxin, the oleander, the beta blockers, and the calcium channel blockers. Then in the patients who are presenting with diarrhea, then we have to rule out the abdominal emergencies and gastroenteritis. In the patients with fasciculations, we have to rule out the ictal phenomena, the mushroom ingestion, and the causes of respiratory depression and frothing like asthma and congestive cardiac failure. Then also the salicylate intoxication may present like this, and the serotonin syndrome, the sympathomimetic syndrome, and the theophylline intoxication, where you find the headache, the sweating, and the tremors. They are found in the theophylline intoxication. So we talk about the management. Now we talk about the management of the cholinergic toxidrome. In the management, we say that yes, atropine is the first treatment of choice. And if the signs of muscarinic access is there, then you should be giving atropine, and you have to keep it giving until there is the dryness of the secretions. Then the seizures, they are to be controlled by the benzodiazepines, and decontamination should be done, but don't let it delay the resuscitation. Also, in patients who are giving a history of organophosphate, bicarbonate, or the nerve agent poisoning, then we use pralidoxin. This is the dose that 2 grams of pralidoxin is being given over 15 minutes, and then it is followed by the infusion of 500 mg per hour. Then we come to the next one. This is the opiate toxidromes, and this is usually found due to the narcotics and the narcotic derivatives, in which there is a binding to the opiate receptors in the central nervous system and the bowel. And the classical presentation is the CNS depression, respiratory depression, meiosis, and the other complications. They include the tachycardia, response to hypoxia and hypercarbia. Then the decreased bowel sounds are there, peripheral vasodilatation with hypothermia, hypotension, and there is a respiratory depression and subsequent coma, which can be fatal. So this is the narcotic toxidrome. You can take it by the mnemonic of CPR3H. You have the coma, there is a pinpoint pupil, then there is a respiratory depression. Then we have the hypotension, hypothermia, and hyporeflexia. So these are the particular opiate toxidrome picture. Then the antidote for this is the naloxone. We can start with a dose of 0.04 mg and titrate it up to 2 to 3 minutes as needed for the ventilation, up to 0.5 or 5 mg, and up to a maximum of 10 to 5 to 15 mg. So naloxone is particularly for the CNS depression, and you can use soda bicarb if the dextropropoxifen poisoning has been in the dextropropoxifen poisoning leading to the ventricular arrhythmias. Then if we talk about naloxone, naloxone is a competitive opioid antagonist at the mu, kappa, and the delta receptors. And the treatment we have already discussed. We start with a bolus of 100 micrograms or 400 micrograms, IM or subcutaneous, and then we give repeatedly 100 microgram boluses every 30 to 60 seconds until we get a spontaneous respiration, adequate spontaneous respiration. And if necessary, then we can start with the infusion, starting with the 2/3 of the initial dose to wake up the patient per hour. Then the next is the hypnosedative toxidromes. The hypnosedative toxidromes means if we talk about the hypnosedatives, they modulate the activity of the GABA neurotransmitter complex. And if we talk about the hypnosedative drugs, they are the benzodiazepines, barbiturates, zolpidem, zopiclone, baclofen, gamma hydroxybutyrate, chloral hydrate, and paraldehyde. And how do they present? They present with a respiratory depression, the bradycardia, hypotension, there is a poor coordination, then slurred speech, ataxia, lethargy, disinhibition, decreased muscle tone, nystagmus, neurological depression, stupor, coma treatment. It's the supportive therapy like flumazenil is being considered. Then the sympathomimetic drugs. What are the sympathomimetic drugs? If we talk about the sympathomimetic toxidrome, they have an activating effect on the sympathetic nervous system through the direct or the indirect effect on the catecholamines. And they directly act on the alpha agonist and the dopaminergic agents. And there are indirect acting agents also which cause increased catecholamine release, inhibition of the enzymatic breakdown or the delayed uptake, like the pseudoephedrine, amphetamines, and cocaine. And if we talk about the cross reactivity, the cocaine can affect the dopamine MDMA and can contribute to the serotonin syndrome. So this is the typical sympathomimetic toxidrome. Means you can have a tachycardia, hypertension, hyperthermia, hyperreflexia, mydriasis, diaphoresis, but with the normal bowel sounds. And other associated symptoms may be pressured speech, the flight of ideas, paranoia, bruxism, tremors, chest pain, and rhabdomyolysis. So this is the sympathomimetic toxidrome. We see the cocaine and amphetamines. See, you can see the mydriasis, the diaphoresis, hypertension, tachycardia, tachypnea. Then there is the increased bowel sounds and hyperthermia also. And if we talk about the differentiation, how do we differentiate from the anticholinergic toxidrome? Like you won't find a dry skin in such patients. So this is the marked difference. If you find a dry skin, then it is anticholinergic toxidrome. If you find a decreased bowel sound, then it is anticholinergic toxidrome. But in this case, either there is an increased bowel sound or there is a normal bowel sound. And there will be a diaphoresis instead of the dry skin. So this is how you differentiate between sympathomimetic and the anticholinergic toxidromes. So if we talk about the treatment it includes the treatment for hypertension and the tachycardia, like the titrated benzodiazepines are the first choice. Then the phentolamine 1 milligram IV, it is repeated every 5 minutes. Then we use the titrated vasodilator infusion like the GTN or nitroglycerin. Then we never give a beta blocker because it can lead to an unopposed alpha stimulation and vasoconstriction. So we don't need a vasoconstriction in such patients. Then if the patient is having seizures, then you can use the IV diazepam. The second lines are the barbiturates. And if the patient is too much agitated, then you use the benzodiazepines as the first line and droperidol and olanzapine as the second line drugs. The patient usually has hypothermia. So if the patient is having more than 38.5 degree temperature, then the benzodiazepine sedation and the fluid resuscitation is already done. And you continuously monitor the core body temperature. And then if it is more than 39.5, then only a rapid external cooling may be required, because the patient may develop a permanent damage if not done. And the patient may require intubation, ventilation, and paralysis if the core temperature is more than 39.5 degrees. And the hyponatremia is also found. So if it is profound, means when it is less than 120, then the patient is to be given the 3% saline. You can start with 4 ml per kg over 30 minutes, and then keep on repeating and maintain the sodium levels of more than 120 millimoles. Then if the patient is having a cocaine ingestion, then usually we start with a blockade of the presynaptic catecholamine uptake. And also if the patient has a calcium channel blockade, which may lead to the ventricular arrhythmia, we treat such patients with the soda bicarb. And if the patient is refractory to soda bicarb, then defib, and if not, then dignocaine is being used at the rate of 1.5 milligram per kg intravenous. Now we come to the serotonin syndrome. So serotonin syndrome, it is the classical manifestation of excessive stimulation of the serotonin receptors in the CNS. And this is a life-threatening toxicity, and it rarely follows the single SSRI ingestion. So it is more common with a combination of the SSRIs with the MAO inhibitors. And what are the causative agents? They are the analgesics and antitussives like the dextromethorphan, fentanyl, pethidine, and tramadol. And if we talk about the antidepressants, the SSRIs, the SNRIs, the TCAs, and the MAO inhibitors, they are the particular causative agents. And the drugs of abuse, they are the amphetamines and the MDMA and the ecstasy. And the herbal preparations, there are, so I don't know whether we get it in India or not, but this is the herbal preparation. And the tryptophan and the lithium, which are used in the psychiatric drugs, they also cause such type of syndromes. So in this, there is a classical presentation, there is a classical triad of autonomic stimulation, diarrhea, autonomic stimulation, neuromuscular excitation, and the mental state changes. So this is the classical triad which is found in the serotonin syndrome. In the autonomic stimulation, the patient has diarrhea, then the patient has flushing, hypothermia, mydriasis, sweating, and tachycardia. And in the neuromuscular excitation, the patient has got clonus, hyperreflexia, there is an increased tone, myoclonus, rigidity, and tremor. And mental state changes, the patient may have anxiety, agitation, psychomotor acceleration, delirium, and confusion. So now, how is it confusing with the anticholinergic toxidromes? So it is similar to the anticholinergic toxidromes. However, this has diaphoresis, nausea, and vomiting. Okay, so like as compared to the anticholinergic, which is dry as bone. But in the serotonin syndrome, the patient will have diaphoresis, nausea, and vomiting. So, like, you can just remember that I am dry as bone and she is hot and wet. On a lighter note, you'll be easy. It is easier to remember that she is always hot and wet. So, see, this is the difference between anticholinergic and the serotonin syndrome. So this is just a gist of what we have just discussed, that there are the mental changes, and there is the autonomic instability, there is a neuromuscular hyperactivity, and these are the particular causes which have the, this is just a tabulated form of what we have discussed. So if we just talk about the illustration, the patient will have a hyperreflexia. Means the moment you touch the knee, the patient will have a hyperreflexia. The patient will have a bruxism. The patient will come with a grinding teeth, sweating. Diaphoresis is also always there. Then the patient will have a rigidity, cogwheel rigidity is there. And the patient will be vomiting, nausea and vomiting is there, and the tachycardia is also found. So in the management, you can, the first management obviously is the supportive care. The patient may require intubation and ventilation, plus minus the paralysis if coma or recurrent seizures or hypothermia is there. The antidote is cyproheptadine 8 milligram, which is a selective serotonin antagonist, though the efficacy has not been proven and not indicated in severe serotonin syndromes. It may be useful in mild to moderate serotonin syndromes which are refractory to benzodiazepine. The patient always requires an ICU admission if severe, and the symptoms are likely to resolve with complete recovery within 24 to 48 hours. Then we come to the neuroleptic malignant syndrome, which is a rare and potentially lethal because of the use of the neuroleptic malignant medications. So the etiology is still controversial. It may be due to the deficiency or the blockade of the dopaminergic neurotransmission in the Negros trial, the mesolimbic and the hypothalamic pituitary pathways. And we always suspect if the patient presents with one of the with the following toxidrome and has a history of ingestion of one or the more neuroleptic drugs. So in this, the patient will have a typical confusion, delirium, stupor, or coma. The patient will have an autonomic instability in form of hyperthermia, tachycardia, hypertension, respiratory irregularities, and cardiac dysarrhythmias. And the patient will have a lead pipe rigidity in comparison to the previous where we had a cogwheel rigidity. This patient will have a lead pipe rigidity. So generalized bradykinesia or akinesia, the patient will have mutism or staring. Then the patient will have a dystonia and abnormal postures. And the patient will also have involuntary, abnormal involuntary movements with the incontinence. So if we just take this patient, the patient will have mydriasis. You can see the diaphoresis. The patient is agitated. That's why the paramedic is holding his hand. Then the patient will have a autonomic instability. The patient will have a hypertensive state. Then the patient will have a clonus and tremor in the lower extremities. There will be hyperreflexia. There will be increased bowel sounds, and the patient may have diarrhea also. So this is the picture which you can remember, and all the things will be, the moment you see the patient, you can easily see that, yes, this is the neuroleptic malignant syndrome patient. So in the management, we need to have a supportive treatment. Then we may need an intubation or paralysis, and the role of benzodiazepines in such patients is controversial because they may play a part in causing the neuromuscular syndrome and the use of the neuroleptic malignant syndrome, and the use of specific agents like bromocriptine or the dopamine agonist in moderate or severe cases and then the dantrolene in severe muscle rigidity is used, and you may need a ECT if the patient is refractory. ECT is electroconvulsive therapies. पहले बोलते थे ना करंट लगाना पड़ेगा, that electroconvulsive therapy. This may increase the central dopaminergic activity. So if we just briefly come to our approach to the patient. So if the patient comes to the casualty of a toxidrome, so first of all, what we have to understand is that all toxidrome patients, they are having a very less morbidity. Okay, so in such patients, the main aim of such patients, or the treatment of such patients, is the main aim of treatment of such patients is to first to stabilize the patient. Okay, because we don't want any unnecessary intervention in such patients, because though these poisonings can be fatal, but a large majority of these patients, they present with a toxic exposure and they suffer a very minimal morbidity and usually recover fully if treated. So it is important to weigh the risks and intervention as compared to the potential benefits of these drugs. Okay, so first is to do a rapid stabilization. So as the golden words are ABC. So you have to establish the IV access, then place the patient on the monitor, then obtain the glucose, then the core temperature and the ECG is to be taken. So this is the initial rapid stabilization after the ABC, like the airway, the adequate gas exchange and the circulation is maintained. Then you just go for these investigations and you give the supportive care, like you treat the hyperthermia, you treat the seizures, and then consider the decontamination if appropriate, if needed. Okay, then you go for the proper history. So you have to obtain a thorough history of the actual and the potential exposures. Okay, so you can use the information from the friends, the family, or even the pre-hospital personnel, and always inquire specifically about the use of some over-the-counter drugs in such patients. Okay, then you then go for a proper physical examination, a thorough physical examination, to ascertain the signs and the symptom, the signs of the potential toxidrome. Okay, so this we have just tabulated in this flow chart, that you examine the eyes. So if the patient is presented with meiosis, then you just see the skin. So if the skin is dry, then the patient may have come with a opioid poisoning or a sedative hypnotic. But if the patient is having a diaphoresis, then the patient may be of cholinergic toxidromes. So after eyes, you see the skin in the same after eyes. So eyes, this was meiosis. Now we see a dilated pupil. So the patient is having mydriasis. Then you go for the skin. If the patient is having a dry skin, then anticholinergic toxidrome. But if the patient is having a diaphoresis, then you see the muscle tone. If the muscle tone is normal, then the patient may have a sympathomimetic or the sedative withdrawal. But if the muscle tone is increased, like we had cogwheel rigidity and the lead pipe rigidity, then you see the reflexes. If the patient is having increased reflexes, then it is the serotonin syndrome. But if the patient is having a decreased reflex, then it is a neuroleptic malignant syndrome. So this is how you do a management of proper emergency care management of a toxidrome if suspected. And these are the various conditions where this is just a tabulated form of what we have studied or what we have just gone through. This is just a summary of all these things. So if we talk about the anticholinergic conditions or the toxidromes, then you observe the tachycardia and hyperthermia. The patient will have a mydriasis. The skin will be hot, dry, red. The bowel sound will be sparse or absent. The neuromuscular tone will be normal. The reflexes will be normal. And the mental status is agitated delirium. Like if we talk about the cholinergic toxidromes, the patient if the patient is having muscarinic side effects, then the patient will present in bradycardia. But if the patient is having nicotinic, more of the nicotinic side effects, then the patient will present with tachycardia and hypothermia. The patient will have a meiosis, or the pupils will be constricted. The skin will be sweating. The patient will be sweating, or there will be a diaphoresis. Then the bowel sounds will be hyperactive. There will be a fasciculations and the muscle weaknesses there. The reflexes, though, will be normal, and the mental status agitated, confused, and patient may present in coma or seizures also. In the opiate, the patient presents with tachycardia, bradypnea, hypotension, and hypothermia. The patient will have a meiosis. Then there will be a peripheral vasodilatation, maybe hypothermic or maybe cool, or the patients will have a decreased bowel sounds. The patient will have a normal neuromuscular tone, normal reflexes, but the patient will have a CNS depression and coma. In the hypnosedative toxidromes, the patient presents with bradycardia, bradypnea, hypotension, and hypothermia. The pupils, there will be a nystagmus. If we talk about the eyes or the pupils, the skin will be normal, the bowel sound will be normal, there will be a decreased muscle tone, or the patient may also have ataxia. The reflexes are normal. The mental status, the patient will have a slurred speech, the patient may present with stupor, disinhibition, CNS depression, or coma also. If we talk about the sympathomimetic toxidromes, the patient will have tachycardia, tachypnea, hypertension, and hypothermia. The pupils will be dilated, or there will be mydriasis. The patient will be sweating, or diaphoresis is found. The bowel sound will be normal. There is a neuromuscular excitation, or the tremors are there. The patient presents with hyperreflexia, and the patient will be agitated, pressured speech, and the flight of ideas or paranoia will be found. And if we talk about the serotonin syndrome, there will be tachycardia, tachypnea, hypertension, and hyperthermia. The patient will have a dilated pupils, or mydriasis will be there. The patient will be sweating or diaphoresis. The patient will be, or the bowel sounds will be hyperactive, and the neuromuscular tone will be increased, and especially in the lower limbs. And the reflexes will be hyper. There will be hyperreflexia or the clonus. And the mental status, if we talk about, the patient will be agitated, and the patient may progress to coma. And neuroleptic malignant syndrome, the patient presents with tachycardia, hypertension, tachypnea, and hypothermia. The patient will have mydriasis or the normal pupils. The patient may be sweating but will be pale. The bowel sounds are normal. The patient will have a lead pipe rigidity. Then there will be a bradyreflexia. The reflexes will be less. The patient will be having typical mutism, staring, and bradykinesia or the coma. And this is how we can just correlate with our presentation of the patients. And these are the books which we have referred to in making these slides. So if you want, you can just go through these books if you want any detailed statement. Thank you very much for this patient hearing. And if you have any questions, we can take up.